Lee Owano and Hazel Moran with Alexion speaking regarding Cmmi Part B, and we'll have Patricia Egan with the National Lymphedema Network speaking on the Lymphedema Treatment Act. I'll be giving an update on SB 1095, which is an initiative by the Rdla Foundation to expand newborn screening in California. And finally, Max Bronstein, my colleague, will be giving an update on Rdla activities around Capitol Hill. So we will get started with Samantha. Samantha, are you there?
I am.
Great.
Great. So, excuse me. So you guys will be receiving, or maybe have already received, our Dear Colleague letter, which is the letter that members circulate amongst themselves to try to gain support for their bills. So a little bit about how this originated. As I'm sure you know, the Alliance for Regenerative Medicine had approached Senator Tammy Baldwin about this bill some time ago, and she'd introduced it. And our office has sort of become fast partners with the Alliance for Regenerative Medicine because my boss is the last remaining PhD scientist in Congress. So he is, really takes his role as a scientist very seriously, and has been very interested in the CRISPR-Cas9 developments in the gene editing technology. And so through that introduction, the Alliance asked us if we would consider being the House sponsor to Senator Baldwin's bill, which we readily agreed to. And so it's a pretty simple, straightforward bill that asks the FDA to use their convening authority to establish a public-private standards coordinating body, sort of looking ahead at the rapidly developing field of regenerative medicine, and looking at ways to make sure the FDA has the tools that they need to approve these therapies once they're proven to be safe and effective. So the bill, we just introduced it a short time ago. It doesn't have any co-sponsors as of yet because we're trying to get a Republican to be our co-lead. Sometimes when you get a lot of Democrats jumping on a bill, it can scare off some of the more moderate Republicans. So we're trying to stay away from that. But the reception so far has been positive. So we're cautiously optimistic that this will at least raise the level of discourse in Congress. And I'm happy to take any questions, or we can wait till the end.
Great, Samantha. I will open up the lines right now. If anyone has any questions for Samantha, feel free to go ahead.
So Samantha, this is Pat Egan. Oh, go ahead.
Go ahead. No, go ahead.
All right. So Samantha, this is Pat Egan from the National Lymphedema Network. And I'm just curious how the Regenerative Medicine Act, how S2443 connects with the 21st Century Cures Act, which is, making its way through the Senate now, because it sounds like there are a lot of common interests and all of that between these two pieces of legislation.
Sure. So as you guys may know, the House has already passed the 21st Century Cures Act, which we were very excited about, and the Senate is still working on that. So I haven't actually asked Senator Baldwin's office if they're trying to roll this into a larger package. I know there's been some rumors that maybe the Senate won't be able to do one large package, but that they might split it up into a bunch of little ones. So we'll see what they decide to do with that. I know they've got their hands full over there, avoiding a Supreme Court nomination. But, I think that what we've learned in our time, so the Congressman Foster is a Democrat, so what we've learned in our time in the minority is that it's best to take a multi-pronged approach to things like this. And so I think you're correct that this is certainly, supportive of what the 21st Century Cures Act hopes to do. And we're hoping that with all of the new research and development that will be spurred, assuming we can get this thing passed, we really want to make sure the FDA is ready, and we're confident, that they will be. But we want to give them the tools to have at their disposal the expertise to make sure that we can get these hopefully, curative and at least life-extending therapies approved in a timely manner.
Thank you.
And thank you, Samantha. This is Ron Bartek of the Friedreich's Ataxia Research Alliance with one other question about the Act itself. And to what extent does it provide, or what kind of tools would it provide to the FDA to be ready for regenerative medicine applications?
Sure. So our understanding, and I believe the Alliance for Regenerative Medicine's understanding, is that the FDA already has a good amount of authority in this area. And so this is just sort of codifying, giving them sort of political backup, so to speak, to do the things that we ask them to do, such as the standards coordinating body, working with stakeholders and, regenerative medicine manufacturers, clinical research, academic institutions, things like that. And then, empowering the standards coordinating body to work with laboratory, regulatory science research in developing standards that would support evaluation of these products. So we are, confident that the FDA is already doing, the research that they need to be prepared for these things. But we see this bill as giving them sort of just another tool to make sure that they're reaching out to all of the available stakeholders that are going to want to have a say.
Thank you. Very helpful. Thank you.
Do we have any additional questions for Samantha? Well, thank you, Samantha. We'll be forwarding along the Dear Colleague letter to the attendees on the conference, and thanks for giving this update on Senate Bill 2443.
Great. Thank you all so much.
All right. Next, we have Leo Wano and Hazel Moran with Alexion Pharmaceuticals. They're going to be speaking on Cmmi Part B.
Sure. Thank you. I appreciate you all taking the time to be on the call. So just by way of background, you may know this, but as part of the ACA, Congress established the Center for Medicare and Medicaid Innovation under the Centers for Medicare and Medicaid Services to test new payment models that might reduce expenditures under Medicare, Medicaid, or CHIP, Children's Health Insurance Program. And the key here being that the statute states it has to make those changes while improving or maintaining care quality. And on March 8th, CMS published a proposed rule to test changes to the way that physicians are reimbursed under Part B for prescription drugs through a 2-phase demonstration program over 5 years. And in phase 1 of the demo, CMS is actually going to be reducing reimbursement for drugs covered under Part B from the current average sales price, which is known as ASP plus 6, and bringing it down to ASP plus 2.5%, plus a flat furnishing fee of $16.80. Phase 2 of the demo experiments with the pricing for specific therapies or groups of therapies by trying out 4 different strategies, and I'll just name them quickly. Reference pricing, indication-based pricing, discounting or eliminating cost-sharing, and risk-sharing arrangements based on outcomes. This is a concern only because the expansive scope of the proposed rule does not reflect the spirit of the statute that established CMMI, which states that, as I referenced before, CMMI exists to test innovation payment and service delivery models to reduce program expenditures. In this case, however, rather than trying something out in a couple of states, this demonstration, which really isn't a demonstration, is rolled out nationally, and participation is, in fact, mandatory. CMS provided only 2 months for comment letters on the proposed rule, setting a deadline of May 9th, which is in just a couple of weeks. And because the proposed start dates could be as early as late summer of 2016 for Phase 1 and as early as January 1, 2017 for Phase 2, it's reasonable to question how seriously CMS can weigh and incorporate any comments before issuing a final rule. So on the patient impact side, because many rare disease therapies are single-source drugs, patients will find themselves between a rock and a hard place should their doctor start refusing to write a script for their therapy due to the requirements of the CMMI demonstration. And if the purpose is to encourage doctors to prescribe therapies to patients based only on cost, it makes the most sense for CMS to focus the demo on multi-source drugs where options exist, because in cases where there is only one definitive therapy, the only choice a doctor will have under this demo is whether to prescribe the drug or not, and not administering the therapy a patient needs isn't an option for which, CMS needs to test outcomes. We know what will end up happening, and that means increased cost and utilization by the patient elsewhere in the healthcare system. It may force patients stable on their current therapy as well to switch to a different therapy, and may result in doctors struggling to keep their practices open, encouraging the trend that we've all seen of consolidation between hospitals and providers. And as you know, such consolidation often results in forcing patients to travel farther to find a doctor to treat them. So on the congressional front, several members of Congress have expressed concern, and we understand that they are preparing a bipartisan letter to send to the administration. Things are not firm right now, but as they tend to solidify, we will end up informing Max so that he can keep everyone on this call in the loop. And I want to pass it over to Hazel, who handles our alliance development, to speak on patient group efforts.
Thanks, Lee. Can everybody hear me?
Yes.
Okay, great. So there has been a lot of patient advocacy activity, specifically on the oncology side. The providers, COA, has taken a lead in organizing a website to basically weigh in with members of Congress opposing this. There also have been, from the patient side, a lot of activity with regard to submitting comments to CMS directly. I understand that Cancer Support Community, ACS CAN, the National Patient Advocate Foundation, and the Arthritis Foundation, and PIPSI are all weighing in. So why we are bringing this to Rdla's attention is that we would like to ask Rdla as a clearinghouse of information to inform the membership that this is an issue that we encourage mobilization around, specifically getting the communication out about rare diseases not being included as part of this demo. So the ask really is to see if there are others in the community that are weighing in here, and if there's some organized activity on the part of the rare disease community to submit comments to CMS on this.
Great. Would you like us to open it up for questions?
Yes, please.
Sure. Okay. Here, I'm opening up the lines now. So if anyone has any questions for...
Hey, it's Keith Suttard on behalf of Horizon Pharma. I would just echo what Alexion is saying here. There has been a good deal of patient engagement on the oncology side, but not as much on rare disease side of things, and it's something I think would be helpful in this effort and that we would support as well.
Hi, everyone. This is Lauren Nath at Bio, and if I could just chime in here as well. We had a briefing on this issue at our offices a couple of weeks ago, and we had standing room only, so I know this is an issue that is at the forefront of many groups' minds. And in addition to oncology, the rheumatology disease area has been really active. So I know that the Arthritis Foundation has been working hard on this issue, and my understanding is that there's going to be another sign-on letter for patient groups only. So once we see that, we can send that to Max, and he can send that out to this group. I did just want to follow up on some late-breaking news that I just heard from our government affairs team. Bio has been working really closely with the Senate Finance Committee as well as E&C and Ways and Means on the House side. And our understanding is that Senator Hatch is working closely with Wyden, and Hatch is eager to do a letter to the administration. And so, they've asked me to convey that to the extent that major organizations are working on this issue and that you'd be willing to weigh in with Wyden and other Senate Democrats, that would be very helpful. And then similarly on the House side, we understand there's a lot of interest with different members and that there will be a bipartisan letter going to CMS. we understand that it will be led by a Ways and Means Republican, and then that Representative Neal from a Democrat from Massachusetts has expressed interest. So similarly, if your organizations have relationships with that office and you'd be willing to weigh in, and if this is an issue that you're working on, I think that would really go a long way. So I just wanted to chime in that this is something that BIO is also very concerned about and following closely, and if we can ever be a resource, please don't hesitate to reach out.
And Hazel, you mentioned a website that that is available. If you think that would be a helpful resource for all of us, or if there are other websites you think would be helpful,
absolutely. I'll send it over.
Give us that link.
Yeah, absolutely. I'll send it over so you can distribute it.
Absolutely. We'll forward it along to the attendees on the call.
Great.
Does anyone else have any questions or comments? Great. Thank you, Hazel and Lee. So next up, we will have Patricia Egan with the National Lymphedema Network, who will be speaking on the Lymphedema Treatment Act.
Thank you, Max. Thank you. And yes, I really appreciate this opportunity to tell people about this it's a simple act, but it's very important. The Lymphedema Treatment Act, HR 1608 and S2373, is a bipartisan and bicameral piece of legislation. The reason why we are moving forward with it is because as soon as patients go on Medicare, even if they've had insurance coverage through their employer or their family, they no longer have coverage for their compression garments and supplies, which are absolutely essential to the containment of the swelling associated with lymphatic diseases. Lymphedema is kind of an umbrella term, and if you look at the definition that's on the site at NORD, you'll see that there's about 12 different diseases that are considered rare, all sort of lumped in under the name of lymphedema. At any rate, patients and their representatives went to 2 Secretaries of Health and Human Services, and both Secretary Burwell and her predecessor said, if you want this coverage, you have to take it to the Hill. So that's the origin of the Lymphedema Treatment Act. It was introduced by Representative David Reichert from Washington in March 2015, and in the Senate by Senator Maria Cantwell just this past December. The next slide. So there is a grassroots advocacy group. It's all volunteers, mainly it's patients and caregivers and therapists. And through the work of this 100% volunteer group, we have had 2 lobby days, and in fact, they're in DC right now. Today is their last day on the Hill, going around to members of the House, members of the Senate, to secure additional co-sponsorship and support on the Hill. Next slide, please. Right now, we have 202 co-sponsors in the House and 14 in the Senate. The reason for the difference is because the Senate bill was only introduced this past December, whereas in the House, we've been working on it for over a year. And the coverage is important. It's not just for lymphedema patients, but anyone who needs compression as part of their daily care needs this coverage. So we ask that, I can tell you that the National Lymphedema Network, we are members of NORD and very supportive of the rare disease initiatives at the state and local level. We ask that other members of the rare disease community please take a look at the Lymphedema Treatment Act and include it in your legislative discussions. Just be aware that this bill is gaining momentum, and we are working very hard to bring it to a vote in this Congress. So does anybody have any questions or about this legislation?
Here, I will unmute the lines right now.
Oh, okay. Thank you.
If anyone has any questions, feel free to ask Patricia.
Patricia, this is information.
Hello? Yes?
Patricia, could you give us your contact information, email
sure.
address, or whatever?
If you go to the next slide, so the website for the Act, where there's all kinds of information. We have a information package specifically designed for members of Congress, so it's quite thorough. Lymphedema Treatment Act.org, and then you can reach me at the National Lymphedema Network, patricia.egan@lymphnet.org, and down in the footer is also the web address for the National Lymphedema Network.
Thank you very much.
Thank you.
Patricia, this is Mark Yale with the International Pemphigus and Pemphigoid Foundation. I work with, in addition to working with the Pemphigus and Pemphigoid Foundation, I work with the Coalition of Skin Diseases, and we deal with a lot of patients that have open wounds and sores that need compression. And so my question to you, and I haven't had a chance to look at the bill yet, but my question to you is the bill specifically written for lymphedema patients, or would it again apply to any patients with open wounds or wounds that need compression?
So the wound care community works very closely with the lymphedema community, and in fact, we have a wound care physician on our board of directors. My understanding is that even though it's called the Lymphedema Treatment Act, the way that it is written, because this is 5 pages double-spaced, of which 3 pages is history and protocol. So this is a very simple bill. And my understanding is that once it passes, then they sit down with a committee and they will really hammer out the details. But my understanding is that it's not only for lymphedema. It is for anybody who needs these compression garments and supplies, and the wound care community definitely needs them. I neglected to say that even the Women's Health and Cancer Care Act of 1998 does not affect the Medicare statute. So that's the reason why this bill, to bring this into Medicare coverage, we have to get it passed.
Right. Yeah. Well, the Pemphigus Foundation would definitely be interested in collaborating with you. As I mentioned, we definitely have a lot of patients that have wound care issues. So I will definitely be contacting you and take a look at the bill and see what we can do to help support.
Thank you so much.
Thank you.
Any other questions? All right. You have all the, truly, www.lymphedema-treatmentact.org is the place to go.
Great. Thank you, Patricia. So next, I'll be speaking, this is Vignesh Ganapathy again with the Rdla Foundation for Rare Diseases. I'll be speaking regarding SB 1095, which is our newborn screening initiative here in California. To give some background on newborn screening nationwide, under current law, the newborn screening panels in each state amount to basically a patchwork of different screening tests. They vary as much as 29 screens in Texas and 52 in California. And of course, as many of you would understand, that leads to significantly disparate health outcomes for babies born in many of these states. Newborn screening is incredibly important in making sure that babies are diagnosed early, and with early diagnosis comes early treatment. It can make sure that we're able to address many of the harms that damage that could face these children moving forward. So we launched this piece of legislation in California as sort of a considering California's role in leading on newborn screening in order to try and duplicate it in other states as well. So again, early detection and treatment can help avert costly medical procedures. Here are a couple of facts surrounding this. For example, a spinal fusion surgery alone can cost around $100,000, whereas treatment costs by way of transplants and enzyme replacement therapy, gene therapy can often be much cheaper over the term of a child's life, as well as ensuring that children are treated much earlier so their symptoms don't get much worse. Additionally, many states have to spend a lot of money on mental health services and developmental care. In California, it's estimated that for every dollar that's spent on newborn screening, there's savings of $9.32. So you save nearly 90% of the cost. On the federal level, the Secretary of Health and Human Services convenes an advisory committee on irritable disorders in newborns and children. This committee is tasked with assembling a uniform screening panel known as the RUSP, the Recommended Uniform Screening Panel. And this panel approves diseases to be recommended for states to screen through a relatively arduous and heavily scientific process. Patient advocates can nominate a disease that can be screened for at birth, and these diseases are then considered by the committee, and the committee looks at everything ranging from the cost of implementing the screen as well as the availability of a treatment. And if the committee finds that the screen is beneficial, they recommend that it be added to the Recommended Uniform Screening Panel to the Secretary of HHS, and the Secretary then essentially signs off on the recommendation. This panel is unfortunately not binding on the states, however. In addition to the 4 years that it takes to add a disease to the RUSP, it can take up to 8 years before a state begins screening for these diseases. For example, here in California, there are 2 diseases that are not yet screened for that are currently on the RUSP, and treatments for them have existed for over a decade, and I'll get to that in just a moment. So the most recent additions to the RUSP are MPS I and XALD, and there's a potential for many diseases to be added in the future, including Duchenne, MLD, additional MPS diseases such as MPS II and MPS VI, and Batten disease. You can find the full list on the website below. It includes primary disorders and secondary disorders, and each one of these also includes a statement on what was reviewed in order to screen for these diseases. So here in California, the state screens for 540,000 newborns each year, and as I said earlier, that's for all but 2 of the RUSP conditions. The 2 conditions are Pompe and MPS I, both of which have had FDA-approved treatments for over a decade. There are 5 public health laboratories in the state, and they use tandem mass spectrometry of dried blood spots, the heel prick process, to screen babies. The reason we focused on California as well is that in 2014, the state passed a bill for screening for ALD as soon as it was added to the RUSP. It was a long process, but through the process, the state legislature basically said that once the federal committee had approved it, it would make sense to begin screening. So in seeking out an author for this bill, we reached out to the state senator who had authored the ALD and SCID newborn screening bills, State Senator Richard Pan, who is a pediatrician and has a lot of expertise in this area. What's SB 1095 would do is it would allow California to begin screening for a disease as soon as it's added to the RUSP. That would eliminate the 4 to 8 year legislative delay and would ensure that there isn't a need to pass new legislation every time a disease is added to the RUSP. So patient advocates and other stakeholders wouldn't have to appear before the state legislature every year or every 2 years that a screen is available. This also ensures that it takes a scientific approach instead of a political approach, and would, of course, at the end, ensure that we're able to treat babies early and save many lives. So as part of the process, the bill has to pass 2 committees in each house. It was introduced in the Senate, so it has to pass the Senate Health Committee and the Senate Appropriations Committee, which is the fiscal committee in California. For many of you that have gone through the process, many states right now think a lot in economic terms. You know, as much as beneficial as it is in terms of saving lives, you know, they see these problems in terms of dollars and cents. So we've been working to accumulate data to show that screening for MPS I and Pompe will save the state money by way of Medicaid funding and other child care services. So this includes the search for diagnosis, surgeries, hospital stays, and again, developmental care. So we have a very good piece of news. Just last week, SB 1095 passed the Senate Health Committee on a unanimous vote. We had many advocates come from across the country to testify, including 2 from here in state. As you can see here, we have all 4 of them appearing in front of the governor's office and in front of the Capitol building. But the process is not done yet. Passing one committee doesn't ensure that a bill becomes law. So there are a number of upcoming dates. The most important one that's coming up very soon is that by May 27th, the Senate Appropriations Committee will be hearing Senate Bill 1095. And hopefully, if it passes the next couple of committees, it's required that the bill be signed by the governor or vetoed by September 30th. So these are the ways that you can help us get this piece of legislation passed. We need as much economic data as cost of surgeries, early treatment versus late treatment as possible. You can contact us directly with any information you may have on that. And of course, you can join the sign-on letter. We currently have over 80 patient organizations that have signed on, including March of Dimes, NORD, the Muscular Dystrophy Association, and Global Genes. And please share this link with your networks. Many advocates might have information that would be very helpful, and many advocates might be affected by this bill that don't know about it yet. So this is a good opportunity to spread the word. And of course, if you're based here in California, we urge you to write letters to your state senators and assembly members, or come to Sacramento and support SB 1095 in person. You can contact me at the email address at the end of this presentation, and we can arrange for you to appear during our the next hearing. And finally, if you have any questions, I'll open up the lines right now, but if you can also feel free to contact me here at the foundation through this email address. So with that, the lines are unmuted. Any questions?
Network, and our board, I brought this newborn screening to our board, and they unanimously said, yes, we should support this legislation. And I will tell the other organizations that it is the Every Life Foundation's website makes it very easy to sign on and add your organization's name and a few comments to support this important bill.
Thank you, Patricia. Does anyone else have any questions?
I think you're going to get a good number of sign-ons as a result of this conversation.
We sincerely hope so. We're also looking for patient stories. So we have a patient stories link that's on the EveryLife website. Just click on newborn screening and you'll find the link there.
So, excuse me, this is Pat Egan again. So we actually have just a poignant patient story. It was written up in the Washington Post health section about a newborn baby who wasn't diagnosed and then at 3 months ended up in the hospital with, you know, a cellulitis infection and all this stuff. At any rate, would you want patient stories, though, that are from out of state? Because this particular patient was in North Carolina, not California.
Of course, Pat. It's definitely helpful since there aren't, because of the prevalence of some of these diseases, you know, it can be, it's definitely helpful to have people from out of state. So.
All right. Very good. Thank you.
If anyone else has any questions, you can feel free to contact me at that at anapathy@everylifefoundation.org. And with that, I will hand it over to my colleague Max Bronstein, who will give an update on Capitol Hill.
Thank you, Vicki. How's my audio?
You're sounding good.
Good. Great. Thank you. So, yeah, I'm going to be giving a Capitol Hill update today. I'm largely going to focus on one update in particular, and that's a story that I feel like I've been reporting on this story for well over a year now about the 21st Century Cures Act / Innovation for Healthier Americans. So I'm going to try to give folks the latest update on where things stand in Congress. So we can go to the next slide. For those who might be new to this thing called the 21st Century Cures Act, I'm sure many of you have been following it, but I know some people are just kind of coming on board now. Basically, there was a very comprehensive and historic bill that passed the House last year in July with an overwhelmingly bipartisan vote. And it had a huge number of provisions in there of interest to folks in the sort of biomedical community, but in particular, lots of provisions of interest to the rare disease community, and I'll go into some of those in the following slides. So it was great that this bill was passed, and then once the bill passed the House, it was then kicked over to the Senate, where it lagged until relatively recently when the Senate Health Committee started taking up individual pieces of the bill that was passed in the House. So I can talk about that in the next slide. So Chairman Alexander, who leads the Senate Health Committee, which is kind of the Senate counterpart for the Energy and Commerce Committee on the House side, basically decided to take a very different approach than what the House did. The House basically pasted all of the bills together for consideration, and what the Senate did instead was wanted to consider each bill individually and do it in 3 separate markups, which all of which have actually been completed now. And if you go to the next slide, I can talk you through each of those markups. So as I mentioned, there were 3 markups. The first one added what was considered several bills, 3 of which I'm going to focus on because they're directly related to rare diseases. One was about, the bill title was Advancing Targeted Therapies for the Rare Diseases Act, and this was a piece of legislation that would allow sponsors to use data from previously submitted packages to the FDA when considering approval of new drugs. There was also legislation in there that would set up a neurological disease monitoring center at the Centers for Disease Control and Prevention. So this was included in the House provision, but when it got to the Senate side, they actually limited the provision to only include the 5 most prevalent neurological diseases, which would basically exclude rare diseases in its current language. So we're hopeful that if and when this bill gets to the point of conference committee, that that specific bill would be broadened again to include rare diseases. And I should mention that all of those had actually passed out of the committee unanimously by voice vote. And then there was another markup held on March 9th. One of the bills considered was the Advancing Hope Act, which actually extended the Priority Review Voucher program that I know many of you are interested in. This is a program that would create an incentive, or creates an incentive for developing treatments for rare pediatric disorders, and this is a program that's existed and several vouchers have already been issued, so we know the program works. It's just kind of a question for Congress as to how long they want the program to run for. Some folks are pushing for the program to sunset in 5 or 10 years, and other folks want it to be made permanent. There's also some language in there that formally establishes the Precision Medicine Initiative, which was basically launched out of the White House, but there was not until now sort of specific language coming out of Congress in law that would authorize the existence of the program and give these various federal agencies the authority they need to collaborate around precision medicine. The Patient-Focused Impact Assessment Act was also passed March 9th, again unanimously, and this is something that would require the FDA to not only use patient engagement in the drug review and approval process, but also to make that information publicly available. And then in the final and most recent markup, there was legislation included that would enhance the workforce at NIH and FDA, and basically what that means is it would allow those two agencies to recruit and ideally retain top talent from the sort of biomedical world to make sure that the agencies are kind of on par with what's going on scientifically and what's cutting edge going on in industry as well. So that's kind of the state of play of things that have passed to date. We can go to the next slide. There were some things that have not yet been marked up in committee. I'm going to talk about each of these very briefly and then go into detail about each one. So on the NIH FDA funding front, this is probably one of the most important items because it's the biggest sort of budget item, and moving the larger package forward actually hinges upon whether or not an agreement can be made on this. On the Senate side, there was no language on compassionate use, although there was language included on the House side, although we did not see any also marked up on the Senate. And also the Open Act was not marked up during the last committee hearing, although the bill was introduced and withdrawn on April 6th. So if you go to the next slide, I'm going to do kind of a deeper dive on the state of play around NIH and FDA funding. So this is really important and really controversial. So when the House passed the 21st Century Cures Act, they basically signed off on about $10 billion in spending. And that's in quite contrast to what's been proposed in the Senate. There have been some Dems who have proposed up to $50 billion in spending. So that's quite a difference to bridge there. Then when you break down for the individual agencies on the House side, the House signed off on $1.8 billion per year for 5 years for the NIH and $110 million per year for 5 years for the FDA. So those are certainly very welcome increases, and they would actually come via a mandatory funding stream, which takes some of the annual appropriating authority out of Congress's hands, and it basically makes it required funding every year. And so there's various proposals floating around in the Senate, but there has not been agreement. There's not been bipartisan agreement yet between the Senate Republicans and Democrats as to what level to fund NIH and FDA at, and there hasn't been agreement on the mechanism either, because some folks are very interested in leaving the annual funding in Congress's hands, and others want to take it out and make that funding mandatory. So the reason why this is so important is that some Dems have actually said that they won't support a larger legislative package unless some agreement can be reached on NIH and FDA funding. And I kind of alluded to this earlier, but we've heard that several Republicans are concerned about the mandatory funding mechanism. And on top of this, we recently learned that Senate Majority Leader Mitch McConnell has stated that if a deal can be made on funding, and of course how to pay for all of these increases, then the bill will go to the floor for a vote. So that's big incentive for a deal to be cut and a deal to be made. So that's really in the hands of some of the folks who've been leading the Senate Innovations Initiative to make that deal. So if you go to the next slide. I should mention one thing about the compassionate use part that I actually alluded to earlier. So this is actually legislation that doesn't have a fiscal impact as far as I know. So It wouldn't surprise me, I'm speculating here, but it wouldn't surprise me if it was included in a final legislative package, assuming we can get to one, even though there has not been any specific language on this on the Senate side. Let's go to the next slide, please. So the Open Act, which I mentioned, it was offered and withdrawn during the final Senate help markup. So the bill did get some airtime at that point. The strategy going forward is our hope is that it would get included actually as an amendment to the package, the larger package that actually goes to the Senate floor for a vote. And we know that the Every Life Foundation is currently looking for co-sponsors, and I'll have more information on that in the later slide. Go to the next slide. So there's been a couple opportunities for advocacy right now. I mean, there have certainly been lots of opportunities along the way, but the current ones is the Bipartisan Policy Center is circulating a sign-on letter for organizations to sign on to. It's basically just urging the Senate to take advantage of all the momentum that has been generated and basically cut a deal to move the legislation forward. So the Every Life Foundation for Rare Diseases did sign on to that, and if you're interested in seeing that letter, there's an email address on the slide, and you can email the folks at Bipartisan Policy Center to get your organization signed on. The Every Life Foundation is also running an alert for the Open Act, trying to get more co-sponsors for that. So that's on the Every Life homepage. If you go to the next slide here. So the big picture kind of path forward is assuming some deal can be made about the funding levels for the agencies and, of course, how to pay for those increases. The bill would then go to the floor of the Senate for a floor vote. And then assuming it passes the Senate, it would then have to get conferenced, and all of the differences between the House bill and what the Senate passed would need to be negotiated and reconciled, and then it would ultimately go to the President for sign-off. So I wish I could tell you what the timeline would be for this process, but there's still some controversy remaining, and definitely, I'm optimistic that folks in the Senate do want to make a deal and push this bill forward, but it's impossible to really call it at this point. So the one thing that will help ensure that the bill gets to the President's desk is everyone's continued advocacy. So that's the update on 21st Century Cures. Just a quick announcement, an Rdla announcement. So I think many of you probably are aware that we host in-district lobby days where we actually help advocates meet with their representatives and senators in district. And in preparation for that, we are actually doing 3 regional legislative conferences this year. So one of which is going to be in Boston. That's on June 28th. And then we're doing 2 on June 30th. That's not a typo. We're actually doing 2 conferences on the same day. One will be in Chicago, and one will be in Seattle. So for folks who live in those cities or states or nearby, we'd really encourage you guys to attend. It's basically a conference that's going to run from mid-morning to late afternoon. So they're not a huge time commitment, and it's a great opportunity to learn about sort of the latest state of play in Congress and to hear, hopefully, from some representatives and senators from your states. So please join for that if you can. We'll go to the next slide here. So that's, about all I have from my end. Thanks for listening, for being on the call. I'd be happy to take some questions if folks have them.
I am unmuting the lines right now, so if anyone has any questions for Max, go right ahead.
So Max, this is Pat Egan again from National Lymphedema Network. So I'm wondering for the bills that are sort of pending in the Senate, and everybody's worried about the money, do you have a CBO score or an Avalier Health score to support your efforts?
Yeah, so we know some of the legislation has already been explored based on estimates from the Congressional Budget Office, or the CBO. So the Open Act, for example, we know has a score of around 800 million right now. I mean, that could potentially change if the duration of the bill is changed at all. So the CBO score is built based on a 10-year time horizon, so that could possibly change. It's a little hard to speculate about exactly how much money will be needed to fund increases for NIH and FDA, because those conversations are ongoing. But we know that The Senate Finance Committee, which is led by Senator Hatch from Utah, has been very actively engaging with the folks from Senate Health, trying to figure out some way to pay for the increases in spending that would be required by the legislation.
Thank you.
Max, this is Ron Bartek from the Friedrich Ataxia Research Alliance, and great briefing, thank you. Back to your points on the different Senate proposals ranging from $8 to $50 billion over 5 years, as I recall, from R's and D's. Do they break that down specifically for into NIH and FDA funding? And if so, can you give us a general range of that breakdown?
Yeah, so it was very clearly delineated on the House side when they passed their bill.
Right.
Those funding marks are in the previous slides, so you can refer to them there. The Senate side, I think there's still a lot of disagreement about the levels and the mechanism. So I know, for example, that some Democrats are very interested in mandatory funding for the FDA, and I know there's sort of lukewarm support for that on the Republican side. So you know, there's still just a lot of controversy about that, and you know, I believe the momentum is there, and kind of everything is aligned at this point for a deal to be made. And I mean, it could be possible that a deal could actually come out by the end of the week. I'd be surprised by that, but you know, this process has been the deal-making process. We're not going to know much about it until a deal is already made. So this is just kind of how things typically go when things are coming down to the wire here a bit. So I'm hopeful that folks can actually get together and get this deal done so we can move the bigger legislative package forward, and hopefully do it before we run out of time, because as everyone knows, there's a lot of distractions this year with the presidential election, and obviously Senator McConnell has expressed a lot of interest in going through the sort of regular appropriations process, which requires a lot of floor time to vote on all of the 12 appropriations bills. So that's going to make it harder to get floor time, although, you know, he has pledged that if we can make a deal, this bill will go to the floor. So, you know, I think assuming we can get there, advocates need to hold him to that.
Great, thank you. Very helpful. Thanks, Max.
Does anyone else have any questions?
Max, Tracy Van Houten here with Noah's Hope. Hey, for the regional legislative conferences, will registration be required or available upcoming?
Yes. So I know we're working on the registration pages, so we should have them out in the next week, I hope. Is that right, Biggie?
Yeah, that sounds about right.
Okay, yeah, so stay tuned for those in the next
Max, actually registration opens on May 9th.
May 9th. Okay, there we go. So a little more than 2 weeks, I guess, but please save the dates, and that way we can make sure that folks can attend.
Thank you, Stephanie. All right, with that, thank you, everyone. You can feel free to contact me if you have any questions about the call today. We'll be putting the slides for the presentation up on the Rdla website at rareadvocates.org. Just click on events and monthly meetings. They should be up within the next hour or two. And I will make sure to forward along some of the additional documentation that our speakers mentioned today. So be on the lookout for that. And finally, our next call will be scheduled for next month, Wednesday, May 25th at the same time. So we will be sending out an invitation for that soon. And with that, thank you, everyone, and hope to hear from you on the next call.
Thank you.
Thank you. Bye-bye.
Thank you.